So the take-home lesson here is that our understanding of infection, disease that matters, and pathogen could benefit by being rethought through and redefined in light of our improved understanding of how these communities actually function within our bodies. The fact is, we are chronically infected with microorganisms, and 99.99% of the time, these infections are beneficial or at least not harmful for us. These concepts are very difficult for endodontists who still believe that bacteria are clonal, or ones that are trapped in Koch's germ theory of disease, which really engenders a way of thinking about disease based on pathogen A always causes disease A. And it takes intellectual effort to get past our historical biases that come from this Cartesian straight line on a graph, linear reductionist model that so hinders our deeper understanding. Try looking at it using a mathematical analogy. Acute Kochian planktonic single organism disease is like addition. 2 plus 2 equals 4. Simple, nonlinear biofilm disease, especially dormant or resting biofilm disease, is more like nonlinear algebra, where many variables cannot be calculated as just a series of simple continuous functions. In nature, it's worth noting that most natural processes are inherently nonlinear. One curious aspect of nonlinear systems is that they appear to the observer to be chaotic and unpredictable, and give an appearance of random behavior, like why some cases work and others don't. But they are absolutely not random. Cancer susceptibility, the weather, earthquakes, where lightning strikes, who gets the flu and who doesn't, come to mind. They may seem random, but they are not. It's just that they are not nonlinear processes, just like chronic bacterial disease. So, okay, it's complicated. To paraphrase Hyman Roth in The Godfather, sorry guys, this is the life we've chosen. Quit complaining and man up. So let's just learn to deal with our issues in a non-reductionist way by understanding that disease expression in chronic microbial disease can take on many forms and require more than one treatment strategy, as we try to account for all the permutations and changing nonlinear variables in our patients and the microbes that colonize them. A non-reductionist way of thinking about this would be microorganisms A, B, C, and D, when within host Z with immune system X, an environment of V seems to be correlated with disease that matters, but other times is correlated with disease that doesn't matter. Which one depends on a multitude of factors, most of which are unknown or poorly understood. To my way of thinking, that is what a careful scientist would say, because it exposes for all to see all the things we don't know or understand, and limits our confidence to things we actually do know. The germ theory of disease usually leads to a treatment strategy of, let's kill all the bugs we can. I'm not sure this is an appropriate strategy for us. We should be smarter than this. I suspect we will never find the silver bullet we all desire, and we're going to do a lot of harm to patients in focusing only on killing all the bugs. Now, I'm just your average metropolitan endodontist trying to do the best I can in my office every day, so I'm going to call on some of my friends to help me here today. These aren't just ordinary friends. They are people who have dedicated their life to understanding complex study design, clinical and research inference, and in the medical community are widely recognized by common consent as the best in the world at what they do. They are all MD, PhD, statistician, epidemiologists with special emphasis on developing a deeper understanding of all the factors that go into scientific and clinical inference, and understanding the difficult problems of evaluating bias and the objective weighing of evidence. I gave Roger Lewis 3 of our best outcomes papers we have in endodontics for him to review. Here is a brief synopsis.
is gone through several of the papers that were provided to me, and I've read them as if I was reviewing them for a medical journal. I'm a statistical methodology reviewer for JAMA, and I spent a lot of time reading studies and trying to write down what are the threats to validity, what do I wish had been done differently. There are such profound problems with your literature basis that it's profoundly depressing. And staring at it for 25 years. Yeah. And so really what we should be thinking about is how to get out of this rut.
So this is a hard truth for many of you. But as I mentioned, I do not believe that the truth can hurt us. It can really only make us stronger, as long as we make up our minds to refrain from any judgment that accompanies that truth. So that's what we're going to try to do here today. This was an email referral I got just before this meeting. I'm sure almost all of you can instantly identify with it. Prior endodontic treatment done many years ago, never any symptoms, and clear indication of an abnormality. Now we need to make a decision. How well informed is our decision? The Robert Koch disease model says we have disease here. Our job is to treat it. After all, your job description is to treat apical periodontitis and cure it if you can, right? Will your retreatment here or your surgery result in this patient retaining this tooth longer than had you waited until it does become symptomatic? Are you sure about that? Any of you have 15-year recall data showing that your interventions work at time frames significant to patients? I'm sorry, your 1-year recalls don't float my boat when it comes to this sort of evidence. So using this as an example, I don't see my job as curing apical periodontitis here. My responsibility is to use my judgment to give the patient the best chance to retain this tooth for as long as possible, not see how many lateral canals I can demonstrate or how I can cure apical periodontitis. The patient may very well have disease that doesn't matter here, or not develop disease that does matter until much later. Second, shouldn't our outcome lid help us with decision with some actual evidence? This is an even more extreme example, and actually the best example. This patient is 92 years old, has always been asymptomatic. The root canal was done 70 years ago and was uncovered in a screening exam. I can ask the same questions here, but I'll assume that is unnecessary. Does anyone think a case could be made that the smartest thing this patient did was not allow a retreatment to occur at some point in the past? If you disagree, and I bet 99% of you do, and want to dive into this because your specialty description tells you your goal is to treat apical periodontitis, how many of you have 20 to 70-year recalls on maxillary laterals that either you or anyone else has retreated? If you have such confidence in your ability to rid the body of apical periodontitis, shouldn't you have some evidence that your retreatment actually works at a time frame that is meaningful for patients? I don't see a lot of 20 to 70-year recalls on retreated maxillary lateral incisors. Do you? The purpose of clinical outcomes research is to inform decision-making, to have some sense of the probabilities that your treatment will be successful and that your patient receives a long-term benefit from either your decision to treat or your decision not to treat. So let's try to understand what some of our problems might be in trying to gain this knowledge from the outcomes research that has been presented here. This is Dr. Steve Goodman. He runs a patient-centered think tank at Stanford that studies these issues in a disciplined and rigorous way. He teaches statistics and inference at both Stanford and Johns Hopkins to physicians and PhD researchers. What he's going to talk about is his experience in mentoring journal clubs for the last 2 decades. Our meeting here today is kind of like a journal club, isn't it? We meet together to review the literature together and make some sense of it? Do our numbers together? Listen carefully to what a very experienced person says about his experience.
Journal clubs are generally exercises in collective ignorance. That is, they speak the language, they say the words, but when it really comes to the numbers, they don't understand what the numbers are telling them. They understand the biology, they understand the clinical part, they understand the all the qualitative dimensions very well. But they don't know how to marry that with the numbers. They don't have a really fine sense of, I know this, from my clinical experience, I know this from the clinical trials. They don't, in some sense, really have a finely graded sense of the weight of the evidence that they're getting from the research. You have a really, you have this judgment when you see a patient in front of you about exactly what the nature of the problem is, how severe, there are all these things that go into it. But you have to have the same sense about the numbers to know how to fit them together. And this is where we have real problems in the medical field, is that we don't, at some level, know how to read our own literature.
Gosh, that sounds like a very serious charge, doesn't it? Exercises in collective ignorance? When I heard this, it really upset me. Is that what we're doing here today? Why would he say this? That we really don't know how to evaluate our own numbers? After all, outcomes is all about the numbers, isn't it? Could this possibly be true? His observations get even worse. We don't know how to read our own literature. We don't know how to weigh evidence. This is not good news. So when we talk about outcomes, what numbers are we actually interested in? Here's another example that may help you understand what I am getting at. This patient came into my office because there are symptoms with the second molar. I determined it is just a perio issue between the wisdom tooth and the second molar. But I noticed there is a suspicious area around a tooth I treated 30 years ago. What kind of outcome is this? The endo was done 30 years ago and the tooth was vital with no unusual periapical findings at the time. But the CBCT scan confirms there is a suspicious radiographic finding on the first molar, which I repeat, has always been asymptomatic. Am I the only endodontist in the room that has had an experience like this? What should we recommend to the patient? Do we even possess the numbers we need to make this assessment, to say nothing about our understanding of them? Since we have defined our specialty as treating apical periodontitis and not observing apical periodontitis, such a definition make it easier or more difficult for us to choose? How does the outcome literature help you overcome these biases? And do you even have the numbers that inform your decision? Or are you really just relying on your clinical intuition and experience, as Dr. Goodman suggests? The incredible overconfidence I see routinely among endodontists gives me pause, given that we really don't know what any of these numbers actually are. These are Dr. Goodman's troubling observations from a lifetime of observing such situations with physicians.
I do think that doctors, all clinicians in general, have to be very humble about what they think they know in terms of outcomes, and that's been the biggest problem, is that every caregiver often thinks they know better how to treat a collection of people, but when subject to actual clinical trials, often that intuition is not borne out.
So sometimes introspection is an admirable trait to have, yes? So why don't we start with some definitions? We recognize three kinds of outcomes: process outcomes, disease outcomes, and patient-centered outcomes. Process-centered outcomes. I'll let Roger Lewis do the definitions.
Outcome assessment. So the difference between process outcomes and patient-centered outcomes. So what is a process outcome? A process is something you do, okay? It doesn't matter to the patient in general, okay? People love process outcomes. Actually, I didn't see a lot of this in the papers that I saw. In one of the parts of the world I work in, which is pre-hospital care, We love process outcomes. We measure how long it took the paramedics to get there, how fast they drove, where they parked, how long it took them to, just ridiculous stuff. Nothing that has to do with how well the patient may have died, but damn, we got there fast. Okay? It's process outcome.
As endodontists, we also love process outcomes. Does it have the look? Look at all those lateral canals. I myself was once enamored of this process outcome. But a process outcome isn't really about the target outcome we desire, is it? It's about the process. These cases from Cliff are all process outcomes. You can't even see the important part of any of the teeth, as in how much tooth structure is actually left. Is there enough structure that the tooth is unlikely to break over the next 20 years? These radiographs don't tell us, do they? These process outcomes are generally divorced in time and space from the true outcome, which is tooth survival over a time period that is meaningful to patients. Disease-centered outcomes. I maintain that our specialty has confused disease-specific outcomes for the outcomes the patient actually cares about, which is functional tooth survival over a 10, 20, or 30-year period.
Then there are disease-specific outcomes, or sort of physician-specific outcomes, and your enamorment, or apparent enamorment, I don't even know if that's a word, with the radiologic appearance of the periapical area, to me, is a disease-specific outcome that's of little or no interest to the patient whatsoever. Because I don't know, does any patient ever come in and say, I feel like there might be a radiographic lucency here. Okay, I'm not sure. Okay? They don't do that, right? They come in when there's a functional impairment, or they are worried because they lose the tooth, or it gets pulled, or it falls out, or something. Okay? So we should design clinical research around patient-centered outcomes.
I know you're all struggling with this, so I'm going to spend some time on it. Let me show you several clips taken over several years at TDO scientific sessions where these concepts have been repeated over and over by various epidemiologists who understand the problem of using radiographs as a surrogate marker of outcomes, probably better than anyone, because it is a common problem in medical inference. It is worthwhile to listen to one TDO's response when Dr. Lewis asked why we were using the radiograph as a surrogate, which brought into focus, are we treating a tooth, a radiograph, or a person? In other words, what is the outcome we are actually measuring?
Is it that you guys have studies that look at this apical radiographic changes as an outcome? Okay, so it's a proxy for success, it's correlated with pain.
And by that stage, we changed our whole profession. Just by saying that, we can't use radiolucent indications on the radiograph.
So who are we treating?
The tooth.
So you have to know that this psychological need to have personal effectiveness, independent of what's perceived by the patient, is shared by all healthcare professions. Okay? I can come up with lots of examples where in my particular specialty, we did the same thing for years, and some people only gave up the outcome measures they cared about when they died. The physician died. Okay? Okay.
2 years later, many of us were still struggling with these concepts. Here someone is trying to convince Dr. Ioannidis that because we make radiolucent areas look smaller, we are therefore accomplishing our stated and proper objective, implying that radiographic appearance is the determinative outcome we should be measuring. Now remember, Dr. Ioannidis was the author who published one of the most downloaded papers in PLOS history, his Why Most Published Research Findings Are False. He is one of the foremost leaders on the subject of statistical medical inference in the medical research community.
With either getting the lucency smaller or resolution, then doesn't that mean that we have improved the situation?
I would buy that if you think that radiolucency is what we call a perfect surrogate of the clinical outcome. And I know no medical discipline that has perfect surrogates of the clinical outcome. A perfect surrogate is not just a strong correlate of the outcome, which means a strong risk factor, it's also a strong correlate of the treatment response, which means that every single patient who has reduced radiolucency will do great. And every single patient who does not have reduced radiolucency will do bad. Do you have that? I mean, if you have that, then this is the first time that I see a perfect surrogate, and I can take it and say that then you have an answer. You don't need randomization. Instead of looking at other outcomes, you just look at radiolucency.
What Dr. Ioannidis is implying here is that because the radiograph is not a perfect surrogate, we would need blinded randomization to determine how good a surrogate the radiograph actually is. Then another person pointed out that relying on the radiograph may actually harm the patient, or in other words, ignoring the surrogate might have been much better for the patient.
You also have the chance of not having any symptoms, doing a procedure, and then you have symptoms
because of the procedure, exactly. So I mean, so far we haven't discussed the possibility of the procedure causing problems on its own. So
you wouldn't know anything about that, would you?
Well, based on my personal experience, I had an endodontic procedure so that I wouldn't have a problem, and then I had a problem. My tooth broke within a couple of months, and I had the non-problem for several years.
Now, Dr. Ioannidis' tooth broke after several months. What we want to know is how many teeth break after 10 years because of the endodontic retreatment. Endodontists should consider what has just been said very carefully. How much confidence should we have that our retreatments have good outcomes 10 or 15 years down the path? Do we have a good sense of what the outcome rates would have been had we avoided retreatments on asymptomatic teeth until they became symptomatic? Dr. Lewis frames the question in a Bayesian way by pointing out that we really don't know what our base rates are.
The reason you cannot use the fact that symptomatic teeth tend to have lesions and therefore, and I should intervene when an asymptomatic tooth has a lesion, is because you have no idea what the denominator is of teeth with lesions who remain asymptomatic for the entire life of the patient. You have no idea.
Now, in primary endodontics, we have some idea, perhaps, that the frequency is high, but in retreatment endodontics, I agree, we have no idea. Let's go back to my case. In my quest to rid this patient of apical periodontitis, what risks are involved in retreatment on a heavily restored bridge abutment? Has anyone ever perforated a bridge abutment looking for an MB2 and therefore immediately compromised the case? Or am I the only one? Has anyone ever made a tooth or bridge more likely to fail after your search and destroy mission fails to find the MB2? For the surgical gurus here, how many of you have 10 and 20-year follow-ups on your surgical cases? I know you don't have them, because if you did, you'd show them. If we have such confidence in our ability to get successful outcomes in such cases, shouldn't we have some evidence besides 2 to 5 year recalls of our cases? A 2-year success is not what the patient is looking for, is it? If it fails at 2 years or 2 months, like in Dr. Ioannidis' case, they no doubt will have wished they never let you try to wipe out apical periodontitis in their mouth, and would consider the decision a poor one, especially since they have been asymptomatic for 20 years. My point is that we have confused a surrogate marker as an outcome instead of identifying the true outcome, which is functional tooth survival, at times meaningful for patients. And that confusion has caused us to make many errors in judgment and harmed a great many patients. As Roger Lewis warns us,
but you should be worried if you continually have studies that show that you make x-rays look better, but the teeth fall out just as much or hurt just as much. I'm not saying they do, but I'm just saying you should be worried. So you instead should design your future studies so that the primary outcomes are things that the patients care about, people are willing to pay for in terms of the benefit, and these things that help you understand baseline risk or the process of disease that leads to those outcomes as a scientific endeavor, those are things you should continue to collect, but don't confuse them with outcomes. Okay, that's the piece I'm making. And in terms of
What kind of evidence should your patient expect you to have when you tell them you can solve their problem, a problem that they don't even know that they have? From a clinical trial perspective, how would we determine what the frequency is of such lucencies becoming a problem over a long time span? The way you find that out is you look at screening dental radiographs in asymptomatic patients with lucencies with prior endodontic treatment, and you look at the fraction in a blinded analysis that anything ever happens with over a 15 or 20 year time frame. I don't know what that fraction is, and I don't believe that any of you know either. So a patient-centered outcome is a metric that measures functional tooth survival over a time period meaningful to patients. Notice there is no mention about radiographic lucencies resolving. I classify the second molar as an excellent patient outcome. I hope all my cases and all your cases remain this good for 40 years. In reading our outcomes literature, I've developed a list of major problems that are shared by almost all of them. Each of these topics is at least a 1-hour discussion, so I'm not going to torture you today any more than I already have. But in the short time we have left, let's just cover one of these. It's one error that is ubiquitous in the best research we have on outcomes. So we're going to talk a little bit about stepwise multivariable selection, which is the most common regression model used in our best papers. So let's listen to Dr. Lewis's critique on the stepwise multivariable selection approach.
In detail, but one of the challenges that you all seem to have is how to interpret data that are gathered in roughly this idea. We have a large practice, and we enroll everybody, we collect all kinds of data about their baseline characteristics, what treatment was given, which we didn't really control, and then some outcome, and let's just assume it's tooth survival so we don't have to have another argument over radiographic findings, okay? And you have all these variables, and you want to ask the question, how important, and this is an observational study, and you want to, just for prognostication, you want to answer the question, how important is each of these variables? Meaning, if the patient smokes, should I tell them that that raises the risk of failure or death of the tooth by some amount? Okay. And there's two comments I want to make, or two general concepts. One is the difference between prediction and variable selection, and the other is collinearity. So hopefully I will remember those both. Okay. When you do a regression model basically asks the question, how much do these independent variables affect the likelihood of the dependent variable, which we're going to use as our example as the dichotomous outcome of tooth survival. And you have a long list of predictor or independent variables. Okay? The way these studies are generally done, I have a table where you list the variables that survive through some complicated model building strategy. Usually something like we screened each of the variables independently to see if it was associated with outcome. Those that were associated with outcome with some particular p-value, we put in a multivariable model. Then in the multivariable model, if they still looked good, we kept them. If they didn't look good anymore, we dropped them out. And we did this through several stages until we had our 12 predictors of outcome or 13 predictors of outcome. Does this sound familiar? I don't know if you guys think. Okay. Because that was about 20 pages I just did right there, okay? Okay. And when you look at that table, there's two pieces of information a clinician might take from it. One is, what are the variables that are important? That's called variable selection or identification of the predictors. The other is, how important are they? So those would be the odds ratio measures for how much does having one of these predictors of a bad outcome increase the chance of tooth failure, tooth death. Okay? Unfortunately, a regression model is fundamentally aimed at answering neither of those questions. A regression model is a way of doing prediction, which is saying if you had a new patient in whom you had measured these 13 variables, can you predict what their probability is of 5-year tooth survival or 4-year tooth survival, whatever it is? That's what a regression model does. So the techniques that are used in at least the papers I looked at, where you do this screening of multiple variables and let the data decide which ones survive till that last table in the manuscript, is highly unreliable. And what I mean by I mean this in a very rigid sense. What I mean is, if you did the exact same study again, you used the same inclusion-exclusion, the same graduate students, just different set of patients, and you did the whole thing, and you went through that whole model-building strategy, the chance that you would get the same list of predictors is very, very close to zero. It's unreliable, meaning you can do the same thing more than once and have a different result, unlike the Carr that's reliable. Okay? So I place virtually no stock in the specific identification of the predictive variables. Okay? So the variable selection strategies used here are inherently unreliable. They're known to be unreliable, and they reflect statistical practice of about 15 years ago.
So what Dr. Lewis is saying here is that this misuse of a regression model is just measuring the noise in our data, not the actual predictors, which is why, if you look at the lit, these studies all come up with different predictors, and this is one of the many reasons Dr. Ioannidis gives for the reason why most research findings cannot be replicated when the experiments are repeated. Small sample sizes, small effect sizes, p-hacking, Kaplan-Meier graphs with few subjects at longer recalls, invalid use of regression models, all these errors, as well as others we don't have time to discuss, should make a careful clinician less confident in what we claim to know. So how do we find out which variables are important? Again, Dr. Lewis.
We really need to come to grips with the fact that observational studies don't tell you what will happen when you intervene. And all of your questions clinically are in choice of intervention, including whether to intervene, how to intervene. And observational data fundamentally will not get you there, because no matter essentially what observational data you show me, I can come up with an alternative explanation for those data that explain the study. I'm not saying the studies are wrong, that would lead to a different conclusion regarding what you should do interventionally to achieve the best possible outcome for that patient.
So these are the points I've tried to make in this presentation. Number one, we should consider redefining our specialty to reflect appropriate outcomes, i.e., functional tooth survival. Number two, I believe we are studying the wrong outcomes in the wrong way and at the wrong time frames. Number three, we don't actually know what we claim to know, and this has led to a lot of overconfidence that has harmed our specialty and our patients. And number four, there are many ways we can improve our evidential base using more coherent study designs.